Another interesting session when we'll be looking at advanced HIV disease in children. And we have Dr. MWATE MWAMBAZI, who will be presenting this session to us this afternoon. And so I think we have been joined by enough people around, so we'll just begin our session. So without further ado, I will invite Dr. MWAMBAZI to just say hello to the network, greet them, and then you can introduce yourself, and then you can go into the presentation. Dr. MWAMBAZI.
Hello, hello, hello. Good morning. Is it afternoon?
It's afternoon
now. Good afternoon, everyone. How are you?
We are good. I don't know if in Quito it's in the morning.
You know, before you eat lunch, it's always the assumption that it's still morning.
Yeah, it's true.
If you eat lunch at 15 hours, you are still in the morning.
Okay.
Yes, but the enzymes, they feel like it's afternoon.
Yeah. Thank you for joining us, Doc.
Thank you so much, and thank you for this privilege to meet up with colleagues from or across the country. I apologize, I may not be in the best of settings, and but I hope to make do with where I am.
We are happy to hear your voice, Doc.
Okay, so I go ahead and begin.
Please go ahead.
Yes, thank you so much. I think today we want to talk about advanced HIV disease. Advanced HIV disease, especially in children. I know that in the recent past, there's been, or rather, in the last decade, there was we almost forgot about what advanced HIV disease looks like because of the very good programs on HIV care and treatment and care and follow-up. But I think we cannot ignore the fact that advanced HIV disease is still a very high possibility. And hence it becomes very important that we discuss these things. Our learning objectives today include, we're going to first of all define AHD, which is advanced HIV disease. We are also going to describe common advanced HIV disease that occurs or affects children living with HIV. We are further going to discuss principles of advanced HIV disease care in children. And then we are going to discuss the package of care for the management of HIV disease in children living with HIV. So before we go ahead, actually, maybe we could ask ourselves this simple question. Can advanced HIV disease, children with advanced HIV disease are at high risk of death from serious opportunistic infections, even after starting ART? Is it true or false?
Yeah, so network, we call upon you. It's your chance to show yourself. And
actually, so people are answering already.
Yes. That's we want them to participate. So do you think this is a true statement or a false statement?
And you can't answer both. You can only pick one.
Yes, very true, very true. I think we can end the poll. I think most have polled for now. Okay, so so this is how people have answered. Most people think it's true. At least all of them except one.
We have a small percentage saying it's false.
Yeah, so let's go. Maybe you can pick it up so that
yes, let's see how it goes, and we see whether we agree or disagree, or how we can learn from one another. The next slide, Mercy.
Can you see?
No, mine is still showing share results.
Oh, okay. I think you can stop it. Just.
I'm the one who should share the results.
No, you can close the window.
All
You
right.
can,
I close this window.
yeah.
Thank you. So as we begin, we just need to look at the background. We do realize that the burden of morbidity and mortality among people living with HIV has markedly reduced, like I mentioned in my preamble. And the last decade has seen a good outlook in terms of management of people living with HIV. Why? Because of the easy access to antiretroviral therapy and very good programs for people living with HIV that have been made available. Over 300 children and adolescents, however, are said to die every day from AIDS-related causes, and only half of the children living with HIV have access to life-saving treatment. This is according to UNICEF 2019. So, in as much as the whole population of people living with HIV, despite them having access to ART, children, I think, in their own right, seem to be a bit behind, and hence we need to up our game in terms of providing care and providing services for children living with HIV. We seem to be lag behind almost all the time. A growing number of these people who are living with HIV are returning to care sometimes, and it has been noted that they'll come back to care with advanced HIV disease following a period of treatment interruption. Children with advanced HIV disease are actually at high risk of death from serious opportunistic infections, even after starting ART. The risk increases with a decreasing CD4 count. These are some of the facts that we need to share with one another. Next slide. Next slide. So what is advanced HIV disease? How do we define advanced HIV disease? According to WHO, one definition is that for adults and older children, our adolescents, and children above the age of 5, advanced HIV disease is one where there's a presence of CD4 count less than 200 cells per millimeter cubed, okay? Or a child, that is a child above 5 years, or an adult or an adolescent who comes in with clinical WHO staging of either 3rd or 4th. So a patient who is on treatment comes back with a CD4 very low, less than 200 cells, we're going to term it as advanced HIV disease. Or they are on ART, they've been following them up for years, then they come back with the stage 3 or stage 4 OIs. We are then dealing with a patient with advanced HIV disease. For children who are less than 5 years of age, okay, children less than the age of 5 years, HIV infection itself is considered advanced HIV disease. So those who are younger than 5, we are going to manage them quite aggressively as long as they are HIV positive. Next slide. So what's the rationale of the current definition of AHD in children? Okay, so severe immunological suppression in children less than 5 years of age is classified based on age-related CD4 categories. I'm sure you remember the percentages that we use, and we don't use absolute numbers of CD4 cell. However, young children have an increased risk of disease progression and mortality, regardless of their clinical and immune staging. So you may have a child, 2-year-old, with seemingly very high CD4 number and even probably very good CD4%, but despite them seemingly looking seemingly well protected or safe, the risk of progression of this disease to severity and even mortality is very high. That's a major reason why any child under the age of 5, regardless of how they seem like, they are going to be managed as advanced HIV disease. Data from the International Epidemiological Database to evaluate AIDS pediatric cohort showed that 80% of children who started ART either had advanced clinical or immunological staging. In another study of children presenting to hospital with severe acute malnutrition, 25% were WHO immunological stage 1 or 2. Okay, so when they were staged 1 or 2, but yet they were already coming with severe acute malnutrition. These findings emphasizes the fact that higher CD4 percentages in children can misrepresent the severity of the clinical disease. Of note, 25% of children starting ART at the age of 5 or less, okay, in the study that was just mentioned, the cohort had no non-WHO stage or CD4 cell count or percentage, highlighting the difficulty of immunological staging in children less than the age of 5, or less than the age of 5 in resource-limited communities. So any child less than 5 years, we're going to term it as advanced HIV disease because of how quickly they can progress. Second question for this afternoon, second question. Which one of the following is not a major cause of morbidity and mortality among children who present with advanced HIV disease? Which one of the following is not a major cause of mortality and morbidity among children who present with advanced HIV disease? Pick one. Is it A, tuberculosis, B, severe bacterial infection, C, PJP or PCP, D, malnutrition, or E, none of the above?
Great, thank you so much. Thank you so much. I think a great talk so far, and we hope the participants network benefiting. And now we want to hear from you, our network. What do you think is the correct answer here? Which one of the following is not a major cause of mortality and morbidity among children who present with advanced HIV disease? Which one here is the correct answer? So we have just 10 seconds more before we can just close this particular session. There's been good participation in this poll, at least more than 40 out of 60 have said and have picked an option. Okay, I'll end the poll. So Dr. Mwambazi, you can see how people have answered?
Yes, I can see.
Yeah, most people think it's E.
Yes.
There's variation here across the other options.
Exactly.
Yeah, so let's see. We can move on to the next. I don't know if you still have that poll window, you can just remove it.
I'll just close. I've learned. We learn every day. I've learned. Just close and you get to the slides. So, advanced HIV disease in children, the major causes of mortality and morbidity among children living with HIV are 1, tuberculosis, 2, severe bacterial infection, 3, pneumocystis jirovecii pneumonia, or PCP as we used to call it when I was at medical school, 4, malnutrition, 5, other diseases that could include cryptococcal disease, okay? However, of note is that cryptococcal will usually be seen in older children, probably the adolescents going up, okay? Third question, the principles of AHD care in children living with HIV disease include these: screen, treat, optimize, prevent AIDS. True or false? Pick one. You guys have leakage.
No, it's to motivate the team that yeah. Okay.
The principles of AHD care include screening, treating, optimizing, and preventing AIDS. Is that true or false? There are 20 people who haven't answered. I don't know, they are not sure maybe. Yeah, sometimes it's best to keep quiet and listen.
Yeah. Okay, I think I'll end the poll. I think there's just been a general agreement that this is actually true. If we can see. Okay, so I think we can move on to the next slide.
Okay. So principles of advanced HIV disease care. Number 1 is screening. Number 2 is treating. Number 3 is optimizing care. Number 4 is preventing the AIDS disease coming up. Okay, to reduce morbidity and mortality among children living with HIV, WHO recommends an intervention summarized as screen, treat, optimize, and prevent AIDS. Routine interventions such as deworming. Remember, you're dealing with children who are under 5, they're still growing. So the deworming, the immunizations, iron supplementation, vitamin A supplementation, and even growth monitoring become also quite crucial, and even more so crucial for children living with HIV. So under screening, what are we talking about when we say screening? So number 1, screening for TB, okay? Every time a child walks into the facility for review, the child is on ART. We need to make it a deliberate effort to actually screen for some of these things. Top on the list is TB. Ask a few questions that will give a hint as to whether there is possibility of presence of TB or not. If you are suspicious, you go ahead and do some investigations to ensure that we are checking out for this disease that could easily cause morbidity and mortality. So use your clinical algorithm followed by X-ray when indicated, and use of the following diagnostic tests to confirm TB as applicable. Remember, currently you don't need to wait for a child to be coughing for 2 weeks plus. Any cough is a suspect enough. Even a 1-day cough is enough for you and me to question a bit more about think about the possibility of it being TB. So investigations, you want to do the gene expert. Okay, we are also going to do your rifampicin check, ultrasound, okay? I mean, rifampicin or ultra on induced sputum. You can do on stool. You can get gastric lavage for younger children. You can even get a nasopharyngeal aspirate, okay, or any other extra pulmonary samples that can be obtained depending on how the child presents. We can also do urine lump to check for the presence of TB or not. Under screening, you want also to screen for cryptococcal infection. Screen adolescents using the serum or plasma or blood cryptococcal antigen, screening, followed by a lumbar puncture if possible, or if positive or the patient is symptomatic. Headache, chronic headache in an older child who's on ART becomes a very easy way of becoming suspicious that this child could have cryptococcal meningitis. Then we look out for malnutrition. Like we mentioned earlier, under 5 follow-ups where we do the weight for height, height for age, mid-upper arm circumference among children 2 to 5 years becomes very crucial in us quickly identifying the seeping in of malnutrition and correcting it before it reaches the AIDS state. Next slide. So that is under screening. We can do some of these quite easily in our ART follow-up clinics. Then, so you said screen, treat, optimize, and prevent AIDS. So that was the screen. Then under treat, treat anything that's supposed to be treated as soon as possible, as effective as possible, so that we don't get a child who is in advanced AIDS disease. So treat TB. Remember we mentioned suspicious okay, investigate. If it's there, treat immediately. Treat severe pneumonia thoroughly. Treat severe bacterial infections adequately. If cryptococcal meningitis was suspected and has been confirmed, okay, treat it as adequately as possible. Treat the severe acute malnutrition according to WHO guidelines. Any child with active TB should start ART as soon as possible or within 8 weeks after initiation of TB. Usually the 8 weeks is mainly for children who have TB meningitis, okay? And this initiation of ART is regardless of the CD4 status or even the viral load, is regardless of the WHO HIV staging. Caution is needed in children living with HIV being treated for TB meningitis, as immediate ART is significantly associated with more severe adverse events when compared to initiation of ART 2 months after the initiation of TB. So the take-home message here is that when we make a diagnosis of TB in a child, we are being encouraged to quickly begin the ART. For other forms of TB, you start your ATT. Within 2 weeks, you start thinking of quickly also adding on the ARVs. But for TB meningitis, we are being advised that we can wait a bit until after about, we consider beginning between in the 8 weeks that will follow, because of the adverse events that have been noted if we begin the ART very early. Next slide. So that is under treat. Again, as we continue under the treat component, a seriously ill child is defined as having any of the following danger signs: lethargy and unconscious, convulsions, unable to drink or breastfeed, or repeated vomiting. Other clinical conditions such as a very high fever above 39 degrees Celsius and age-defined tachycardia or tachypnea. These can be considered based on the clinical judgment. Ours is to, when we see a child who's this sick, we quickly do our assessments, history taking, thorough examination and investigations, and immediately quickly treat whatever ailment this child is presenting with. Next slide. Then you have the optimize. We say to screen, treat, optimize, and prevent AIDS. Under optimize, we are saying repeat ART, rapidly initiating ARVs, okay? Rapidly initiating ARVs where possible, okay? Antiretroviral adherence counseling, very crucial, so that we can optimize treatment and ensure that the patient is adhering to treatment and improving in terms of clinical and also immunological. ART retention, we find ways of how to keep these patients within our care. If they are going to move to another facility, a nice, well-structured referral so that care is continued and the patient is retained in the ART care. Every time the patient comes to the facility, we do the nutritional assessment and we give nutritional support according to the patient needs. Social support becomes very important, both for the family. When you're dealing with pediatric HIV, social support begins even with the parents, the mother, the father, the siblings, and the patient, so that as a whole, the patient is supported. For all the adolescents, you may consider, the people that they interact with, so that you can have a great social support system, which will improve adherence to care. The next slide. Thank you. Then prevent, the last component: screen, treat, optimize, and prevent. The last component is prevent AIDS. Prevent bacterial infections and PCP, okay? How? Cotrimoxazole prophylaxis, very important. Prevent TB, prevent the surgence of the TB infection. How? Isoniazid. Okay, you have your 3-HP and you have your 3-HR. 3-HP is where the anti-TB drugs are given once a week for 3 months. 3-HR, it's a regime where patient is giving the INH and the rifampicin every day for 3 months daily. Okay, so depending on which setting you are in our setting, the 3-HR, the daily one, becomes a better option. So all these to prevent the AIDS disease coming up, showing its ugly face. Cryptococcal meningitis, especially if you're dealing with adolescents, you want to prevent cryptococcal coming up by your fluconazole preventative therapy. Remember, vaccinations for children, depending age appropriate vaccinations becomes crucial. Your pneumococcal vaccines, your human papilloma virus, measles, BCG, depending on the age of the child. Screening, diagnosis, and prevention components of the package of care for children and adolescents with AHD should all be incorporated to prevent any disease that could come up. Next slide, please. So this is a summary of the package of care. You want to screen, you want to treat any illnesses, okay? You want to obviously give your prophylaxis, okay? Rapid initiation of ART and intensified adherence interventions for us to meet the screening, the treatment, the optimizing, and the prevention of AIDS. Next slide. Interventional components of the package of care for children. If you look at this one, it's a repetition of the same things I've just been talking about, but I think this one is in this slide, we're trying to show some age appropriate interventions. So when talk about screening and diagnosis, here we mentioned talking about screening for TB, okay, using the algorithm, chest X-ray, doing the gene expert, and all the other on the samples that you can get from a patient, your LAM. All these can be done in under 5, in toddlers 5 to 9, and even in adolescent children. LAM can also be done in all the children. Okay, cryptococcal antigen screening. Remember, this is more appropriate for children 10 to 19 years. When talk of prevention, prophylaxis, and preventative treatments, your pneumococcal conjugate vaccine, you want to ensure that all children of these, hello, am I there? Hello?
Yes.
Okay, thank you. Obviously, you're not going to do catch-up of pneumococcal vaccine in adolescents and older children. Your cotrimoxazole, everyone needs to get this. TB prevention therapy, everyone needs this. Okay, your fluconazole preemptive therapy, more in order, very usually unapplicable in younger children. Next slide. Again, similar, just it's the same one. Thank you for jumping. It's really same. It's really the same. It's really the same.
Yes, it's the same.
It's the same. It's the same. Yeah. So as we come to the end of this presentation, I just thought that it would be interesting to look at a case. We have this case. This little girl is now 11 years. And the interesting thing is that she's multi-provincial, for lack of a better term. She was actually diagnosed at UTH. I'm hearing an echo. It's okay?
No,
I hope it's not disturbing anyone.
No, right. You're actually very okay. You're very fine, thanks.
Thank you. So this child now is 11 years, but the child was started on heart in 2011 at the UTH. And that time, the CD4 was 23% and was initiated on our AZT3TC MVP. In 2014, the patient was switched to ABC3TC lopinavir as a second line. That was what, 2 years? 2 years after initiation. In 2017, I think at this point, the child was at ADH. 2017, the child was switched to AZT3TC LPV, ritonavir boosted, based on resistant test. And the child at this point had TB relapse. And the CD4 was 99. I think for my colleagues that from the time we started discussing, you can see advanced HIV disease in this patient. One is a child who's been in care, is on ARVs. Two, he's been moving up in terms of the ART regimens the child is on. Despite that, you see the patient coming back with a HIV defining disease and the CD4, which is very low. And in terms of nutrition, the child was said to be stunted at this point. In the same year, he was switched. The girl was switched to ETR, DRV, and rotogravir. And again, in 2021, this child has been switched to darunavir-based, and the viral load is still not undetectable. It's still detectable as of 2021. For the 2022, we are awaiting the new viral load this year. Just show the next slide. Show the next slide. It's about the same patient. I don't know whether you're able to zoom out so that you can be able to see. It's just a portion that I was able to pick from the file for this child. You can see from 2011, the CD4, it's just been there, 458, and by February 2017, it was 99. The viral load, those that were able to get, you see there above 100,000, and then you have, it came down a bit, and then you had 61,000. The latest is 193. That was 2016. The 2021 is the one I mentioned, which is 500 and something. We are yet to get the 2022. This is a child who is already on third line. And you can see when you look at the treatment regimens, those are the ones listed there. And if you look at the comments down, this is a child who I think there's a struggle. So as we manage, I think the idea of bringing a case study like this one is just to indicate that in the presence of care, in the presence of all the ARVs, different options, there's still those children who may come up with very difficult to manage kind of scenarios like this, our little girl. And I think upon sitting down to discuss what the challenges could be, next slide, discussions and challenges, some that came out and that could come out clearly, even probably in other centers for the people that are here, other centers represented, is that number one, as a patient start to get advanced HIV disease, you want to, all those things we mentioned, you want to screen them, you want to treat, thoroughly, you want to optimize care, you want to ensure that you prevent HIV. You are going to ask them to come back more frequently for reviews, and that patients tend to feel like it's an inconvenience, and then you start, doing chochise with the parents. Adherence may become compromised and things like that. So those are some of the challenges that we need to be aware of and be able to see how we can address them depending on the clients that are in front of us. Then the second one is the results of HIV drug resistance. Sometimes they take long to come and they may hinder or they may delay decision-making as to which direction you're going to take, okay? And then number three is there may be few people who may be trained or they may be comfortable enough to manage advanced HIV disease, especially when they reach a point where they are requiring third line treatment. So maybe Dr. Ziambo, maybe we could call for these trainings so that we are ready for such patients that will possibly come to us. And then sometimes a shortage of drugs for certain OIs. Last year, 2021, I had a child, she was 14 at Kitwe Teaching Hospital, and we confirmed cryptococcal meningitis in a child with HIV. And now we were looking for amphotericin B. And she's only one patient out of so many. So obviously the pharmacy, they were like, how many people use amphotericin B? So it may not be readily available. But this particular child who has got advanced HIV disease needed amphotericin B. So we struggled. Luckily, we have a very a pharmacy, the pharmacist with a lot of initiative. Somehow they managed to get us some ampho B for a short few days. Then we continued to manage the child on the fluconazole, and then we were doing the therapeutic taps, and the child walked home talking. So we intensified our adherence, and we've continued to follow up that child. It seems rare, but it's real, and sometimes the drugs to use may not be readily available in our facilities. And then obviously poor nutrition may prolong recovery. So in as much as we are managing the patients and putting them on nice ARVs from this regimen to the next, let's not ignore the fact that a child who is nutritionally stable or well may actually respond favorably to the treatment that we put them on. Sometimes we tend to ignore that, and I think this one is just bringing out the fact that let's be holistic in our management of these children. The next slide. This is the last one. Oh, summary. So take home points. Number one, all children less than 5 years, especially those who have just been newly diagnosed, should be properly assessed in order to rule out advanced HIV disease and provide appropriate treatment. And a child is less than 5 years, is HIV positive, we are not going to treat it with kids' gloves. We are going to be as aggressive as we can so that we don't get a shock of a child who seemed very well. Suddenly, they are dying of severe pneumonia because of this HIV. Second take-home point, the approach to care of children with advanced HIV disease is, I think I've rhymed it many times, screen, treat, optimize, and just prevent these AIDS-defining illnesses. And then lastly, but not the least, prevention services are important to reduce occurrence of OIs, such as cryptococcal meningitis, tuberculosis, invasive bacterial infections, and malnutrition. And I think we did mention all the factors that we can put in to try and reduce these diseases coming up. Messi, is this the last slide? I think this is the last slide. No, we go back
the last slide. This is the last slide.
I think. Yes.
Yeah.
And that's the references. And maybe you can go, are we still going to go back to the poll, to the questions?
Yes, we'll do so.
Okay, we can redo those. So back to question 1. Children with advanced HIV disease are at high risk of death from serious opportunistic infections, even after starting ART. True or false? Choose one. Children with advanced HIV disease are at risk of death from serious OIs, even after they start ART. Others are not answering.
They will answer.
They will, why?
Yeah. Yeah, so anyway, so I think we'll end it here so that we just manage our time.
Yes, please. I think time has gone, yeah.
Yeah, you can just talk to this so that maybe I can speak to it. Please go ahead and say which one is the correct here and why it's correct.
So the correct one is true. Just think of the child, the patient, the case study we had. This is a child who was on ARVs for many years, but still was struggling with tuberculosis. So it's true, children with advanced HIV disease are at high risk of death from serious opportunistic infections, even after they start ART. So it's true.
I think,
the second question,
and that's the emphasis here should be.
Please go ahead.
The prevention aspect of our care. We start them on the treatment, we optimize, but prevention, meaning we need to look out for the opportunistic infections, look out for anything that may cause illness. So, and there's actually a question in the chat, which I'll ask you after this poll. Maybe you can also speak, be referring to the same issues. Okay, so I'm sharing the next question.
Which one of the following is not a major cause of mortality and morbidity among children who present with advanced HIV disease? Which one is not a major cause? Underline the word not.
We should have underlined not, eh?
Yeah, and maybe we should have made it bold. Not a major cause of mortality, because just that is enough.
Mm-hmm. Yeah. Okay.
Yeah.
Sorry, but the screen is saying which of the following are major causes. There's no not.
Oh,
really?
Okay, yes. Sorry, we didn't correct the main poll. If you looked at the one that you have displayed, sorry about this one. I think this one wasn't corrected.
I see.
Sorry
for that.
Yeah.
Okay.
Okay, so but you can go ahead and speak to this.
So the question is asking about which one of these is not a major cause of mortality and morbidity among children. And what we are saying is that all these are.
Yes.
TB can cause major mortality, morbidity, and mortality. Severe bacterial infection can cause severe morbidity and mortality. PCP, malnutrition. So the answer is none of the above is not.
Yeah.
Okay. None of the above is not. Yeah.
Okay, we'll move on to the next one. Sorry for that. This one was completely straightforward, Dr. Mwambazi.
This one is the most straightforward of them all.
Yeah.
The principles of AHD include screening, treating, optimizing, and preventing AIDS. Yeah, I think the question is clear. Yeah. You can tell from the answer, yeah.
All right. No, thank you. Thank you very much, DA Network, for participating. You always make these sessions very, very fruitful and interactive with your participation. So now we had a few questions in the chat box, Dr. Mwambazi.
Let's see if we can address them.
Yeah, so one of the questions was, I think this is, what are the chances of iris when we rapidly initiate ART in a pigs co-infected with extrapulmonary TB, such as abdominal TB?
What's the risk of iris?
Yes. When we rapidly, I think here the key word is rapidly initiate. Perhaps we may just try to explain what is meant by rapidly initiate ART in a child who we are suspecting may have, actually has extrapulmonary TB as a
TB. So I think, well, I don't know, when we say rapidly, the guidelines really are that if you make a diagnosis of a child, we make a diagnosis of tuberculosis in a child, and the child has HIV, your plan is to treat the TB and to control the HIV. So you're going to start with initiate on anti-TB treatment,
Yes.
And as soon as the child has stabilized enough on your anti-TB, usually within the first 2 weeks, you are then starting to plan to add on your ARVs. And
Yes.
from the presentation given, we've been guided that for those with TB meningitis, you may have to wait a bit longer than those with non-TB meningitis. TB, yes, with TB other than TB meningitis. Now, in terms of rapidly, I suppose it means I begin the patient today, I make a diagnosis of TB, and the child has HIV, and I decide just within a space of a few days, I begin the child on both. Remember, both treatments are quite strong, and you want to allow the liver and all the enzymes to be able to accommodate these two new exogenous chemicals. And then their immune reaction, when you start both of them at the same time, you may not know which treatment is affecting what adverse event. So I think the guide really is not to be too much in a rush, because then you may, apart from just iris, you may even increase the risk of other adverse reactions towards treatment. I think that's what I would say. In terms of what is the rate of risk, I may not have the exact answer, but I'll probably say the risk would be higher of iris or of adverse events to treatment if we begin all the treatments at the same time very rapidly. I don't know if it's helping.
I think that's very helpful. Thank you so much. I hope the question was answered. Nixon?
Yes, Doc. I think I got the point, because initially I thought the presentation was like in whichever form of TB, that's co-infection with ART, we rapidly initiate TB treatment. I mean, ART, with the exception of only TB meningitis. But from the explanation, I think we're on course. I've gotten the point. Thank you.
Okay, thank you
so
so
just
much.
to add, Dr. Ziambo, just to add,
Yes. Yeah.
the word rapidly there, when you are saying rapidly initiate ART, it's rapidly within acceptable ranges.
Yes.
Rapidly,
yes.
because sometimes we've had patients, now it's gotten better. We used to have actually the time when people were very scared of treating children with HIV. You would have a patient who was started on TB, months have passed, and we're saying if you don't address the immune, the immune component of this patient, you may not see the advantages of your TB treatment.
Sure.
So
That's
rapidly
true.
means quickly, as soon as your 2 weeks has elapsed and you are happy, your patient is stable, is not severely jaundiced, is stable on your anti-TB treatment. Quickly slot in the ART. Don't wait, otherwise your work done may not be well appreciated. Yeah, that is the rapidly being mentioned there. Yeah.
Thank you so much for clarifying that. Dr. Judith, would you like to step in with your question or comment?
Thank you. Good afternoon, Dr. Mwambazi. Thank you very much for that nice. Thank you very much for that nice, elaborate presentation, and good afternoon to everybody else. In the first place, my understanding for that rapid starting of the ART, I'm just going to give an example. For example, how we do the loading dose in, I don't know about now, but I'm in a different area altogether. But we do like a loading dose in malaria and some other like surgical processes of antibiotic. Probably they wanted to refer to that kind of what you call it, doing as when they say they rapidly. But what we ought to remember, just like Dr. Mwambazi said, if we rapidly introduce the ART, that client has a possibility of reconstituting, forming the reconstituting syndrome, and bringing up a very nasty kind of reaction whereby it can even take away the client. So it's not ideal, just like the guidelines say. Let's stick to the 2 weeks and see how they're going to respond to the ATT, and then slowly introduce the ART. And then for the TB meningitis, as you rightly put it, it takes a little bit longer to reintroduce the ART. I submit. Thank you.
Thank you so much for that comment. And we may need to familiarize ourselves with the WHO guidelines, which actually talk about rapid initiation of ART and those that we find HIV positive. Once we familiarize with that, we will be able to understand in what context rapid initiation is actually being discussed here. And the issue is never to wait to give ART for any other reasons other than the risk of the patient probably having iris and all those other things as discussed. Thank you very much for your comments. I see another comment here, say, good afternoon, Doc. There may be two types of patients here, one newly diagnosed and with TB and already on ART, diagnosed with TB with the one already on ART. We assess the severity, and the new patients we defer ART for 2 weeks. Certainly that's what we do. Thank you for making that categorical. Any other comments, questions from the network? We are remaining with a few 5 minutes or so, 3 minutes or so before we close this session. So far, so good. I can see people are appreciating the presentation. Thank you, Dr. Mwambazi. Several people are really happy with what you shared this afternoon. Okay, so I think with no further comments, are there any thoughts you'd like to add to this discussion, Dr.
Well,
Mwambazi?
not much, just to say thank you. And I think it's gratifying to see a group, to see that there are colleagues out there fighting the same fight as you, fighting for that child out there, so that we can alleviate suffering and pain for these beautiful souls. I just want to encourage everyone just to keep on what they're doing. Well done. And we can still do better in those few that we have missed. We continue picking them up as quickly as possible. We quickly attach them to care and we follow them up. Very crucial so is the counseling. These children are so intelligent. While you think you are hiding data, they are 10 steps ahead of you. Let's talk to them, we engage with them, we start assessing the disclosure and things like that. It helps in terms of adherence, and it helps in preventing, what do you call that, when they just become truant and they refuse and say, Shafinweko, after all, it was not my fault. The more we engage with them, we talk with them, we learn from their concerns, they learn from whatever we know, then we can create a good treatment program and treatment plan, and then we can prevent the advanced diseases coming up and causing morbidity and mortality. Thank you so much, Dr. Zambo. Thank you for everyone for taking this time to listen to me. Thank you.
Spoken as a passionate pediatrician. Thank you so much. So thank you very much, dear network, for joining us this afternoon. And we really appreciate your participation. And we hope that this session has had value in the way you provide care to our children living with HIV. So we end here today, and we will be in touch for the next session in the next 2 weeks. Do have a very wonderful day for today. And Dr. Mwambazi, thank you for always stepping in at that last moment. I appreciate your availability. Thank you so much.
Anytime, Doc, anytime. Thank you.